So welcome along to the coaching corner today. Today we're going to tackle how to do the transvaginal ultrasound, and I'm hoping to give you some tips and tricks for transvaginal scanning. I think this is a topic that isn't tackled very often because of its very nature. It can be quite tricky, especially to be learning how to do transvaginal ultrasound. So for those of you who are new to the coaching corner, I just wanted to let you know this session is being recorded. If you have any questions, feel free to pop them in the chat box. If you don't want your question on camera and you want it towards the end, when we stop the recording, feel free to do that as well. I just wanted to let you know that if you wanted to contact me about anything, you can catch me on Twitter at ZDNow or at ICSound with the underscores, and my email address is there as well. And for any of you who are genuinely wanting to improve your scanning skills, we do have a one-day transvaginal ultrasound course that you can enroll in. So go to the website and you can check that one out. The other option that you have, of course, is to give us a call or get in touch via email and book yourself in for some scanning practice. We do tailored sessions. Whatever your topic of choice is that you need to practice, we can arrange something bespoke for you. I'm going to take this chance to just give our Train the Ultrasound Trainer course a plug. We've got a new course offering in Australia that will be running in July and October. For those of you who are teaching ultrasound, this is a very specific Train the Trainer just about ultrasound and all the tips and tricks for teaching ultrasound. So feel free to check that out on our web as well. So tonight's topic is how to perform the transvaginal ultrasound. And the first thing we're going to tackle is understanding how the image presents. I want to look at the probe moves. I'm going to share with you how I tackle or how I approach the scan. And then everyone's bugbear is how do you find those elusive ovaries? So the first thing you need to understand is that the transabdominal scan with curvilinear probe and the transvaginal ultrasound probe will give you a very different shape sector. So if you're looking at images, you just need to quickly look at the top of the picture here to be able to see the curvilinear probe gives you a wide near field, whereas the transvaginal probe, by the very nature of its shape and where it has to go, has got a tight curvilinear, but it has got a very expansive far field of view. The difference between these probes is, apart from their footprint, is the frequency. So the transabdominal probe is lower frequency, which gives us better penetration to be able to see the deep organs. The transvaginal probe is a higher frequency probe, and because we put it in the vagina right up against the anatomy that we're looking at, we get much better resolution pictures. Let me get my pointer going again. There we go. So looking at the transabdominal scan, we need to be able to have low frequency so we can get all the way through the bladder to see the deeper structures underneath. And so the trade-off there is that we don't get the resolution that we need to. If we look at the bladder here, uterus, and the lining of the uterus or the endometrium, we don't see great detail on a transabdominal scan. Transvaginally, however, because we're right up against the anatomy, we can see much clearer detail. We have the outline of the uterus here, of an anteverted uterus, and here's the endometrial lining. The ovaries are another story, and the transvaginal ultrasound lets us see things that it's just really not possible on the transabdominal scan. So in this image here, we have the bladder outlined here. We have the uterus, and this sort of grey fuzzy blob is the ovary. When we scan transvaginally, because we can be right up against it, and you can see on this image, we're about 2 centimetres away from the ovary there, we now start to delineate that grey fuzz blob, and we can actually see the follicles. And for those working in fertility centres, that means we can count the follicles and give an idea of the fertility, potentially, of the patient. So we have the ovary outlined here with the little black holes in it, which are the follicles. And I've heard these described as like a chocolate chip cookie. So the first thing you need to do is how to hold the probe. And whether you're scanning transabdominally or transvaginally, holding the probe correctly is the first step in successful imaging. But on a transvaginal scan, it really is vital to be able to figure out how to hold the probe so that you can understand the orientation of the image. So if we look at the transvaginal probe, on one side, they might have a little nick or a little indent here, which will indicate the probe marker. Often they'll have a little nick in the plastic molding so that you can clip on a biopsy guide to do oocyte retrieval. And this is the same probe we use for transrectal imaging of the prostate. And so because it goes into the internal cavities, we can't actually see where the needle's going. So we need something to keep it on path, essentially. And if you can look at the transvaginal probe from the side, you'll notice that it is molded so that it's comfortable to hold it in one direction, and it's grooved and molded so that my thumb has got a comfortable resting place and my fingers grip the other side. So typically when you're holding the probe in that longitudinal orientation, it feels right or feels more comfortable in one direction, and if it's upside down, it feels a little awkward. Now, the reason that's all important is because we need to establish where the probe marker is and how we're going to hold the probe. If you can identify how to hold it with the molding and then the thumb groove, your thumb is going to become the probe marker from this point. And we're going to just rest our thumb along that sort of line of the top of the probe. Now, obviously, when the probe is inserted into the vagina and you're under the sheets, we can't see where the probe marker is. So we need to keep a good idea in our mind how the scan plane is oriented versus the patient's anatomy. And so if we hold the probe and keep our grip in that one orientation with our thumb on the top, our thumb becomes the probe marker. And so we have the probe marker side and the non-probe marker side. So you can see here, we're going to hold it with the thumb running along the length of the probe. Once you have that grip in place, and as you notice on the picture previously, you've also got your probe cover that you just do need to keep a hold of. So I encourage you to keep your thumb holding on to that probe cover and don't readjust your grip when you're turning from longitudinal into transverse, but hold the probe, hang on there, don't let go. Keep your thumb on the probe marker. I once had to scan a patient who was a staff member at a practice that I locumed at. She'd had a scan about 6 weeks earlier and now had a high fever and really quite severe abdominal pain. And as I finished the transvaginal probe, their protocol was to cover the probe with 2 condoms. As I pulled my probe out, one of the condoms from the scan 6 weeks earlier was on the end of the probe. I'm super paranoid about losing the probe cover in the patient, so I hang on and I don't let go. So we pop our thumb along the length of the probe there. That becomes the probe marker. The action then comes from the wrist, and we turn from long into trans using our wrist. So as with any of our imaging, the probe marker and the anatomy on the side of the probe marker will always be demonstrated on the same side as the screen marker. And that gives us the indication of which side's which once we're in situ. So we want to pop our thumb, it becomes the probe marker, and we know that wherever our thumb is, the anatomy on that aspect of the patient will be demonstrated on the same side as the screen indicator on the image. In longitudinal, we point the probe marker to the 12 o'clock position, and in transverse, we rotate through the wrist and we point our probe marker to the patient's right side or to the 9 o'clock position. Now, I want you to imagine for a moment, if we're looking at your patient end on, the 12 o'clock position is their head, that's longitudinal. The 9 o'clock position is the transverse. And when we have it in this orientation, the image can make sense. The transverse orientation is the same as what we're using for conventional chest X-ray and our conventional anatomical position. Now, as we know, the textbooks all have our patients with perfect anatomy, and obviously sometimes it isn't perfect anatomy. And so sometimes you can have a uterus that kicks off to one side or the other. So once you establish the longitudinal position of the uterus, I want you to understand and think about where is your thumb pointing on that clock face, because that is your long axis and your transverse plane is at 90 degrees to that, wherever that is. So in this instance, we have the longitudinal axis on this wonky uterus sitting at about 1 o'clock. And so our transverse will be at 10 o'clock at 90 degrees. I think one of the most challenging things about transvaginal imaging is understanding how that image is oriented. And that's because we're looking at everything from upside down now, and we're coming from underneath the anatomy. So when we pop the probe in here, we have our thumb on the top at 12 o'clock. The anatomy on the side of the probe marker will demonstrate on the side of the screen marker. Can I just get you to turn your microphone, your audio off, please? Sorry, I'm not sure who that is. So when we're looking from underneath the anatomy, if we have an anteverted uterus, it will be on the probe marker side. Now, as with other imaging probe orientations, whether it be the linear or the curved or the cardiac, usually the top of the sector is closest to the skin, or closest to the probe, shall we say, and the bottom of the sector is at the deepest part of the probe. So when we look from underneath, that's actually inferior, and at the top of the image and deep in the image is superior. Then we just have to figure out, well, which side is which, and that can be as confusing as it can for cardiac imaging or transabdominal imaging sometimes. So we have our probe marker here. In a longitudinal orientation, we will have the fundus of the uterus, on an anteverted uterus, will be on the side of the screen marker, and the non-probe marker side will be on the other side. So in longitudinal, we have inferior, superior, anterior, posterior. It's kind of like looking at the image side on, and this is where it can get quite confusing. So if we imagine that that's how the ultrasound image, we're just turning it 90 degrees to get it to our positioning here. Now add into that complicating arrangement of things that make it confusing. Sometimes the anatomy is pointing in the opposite direction, and so that can make it confusing as well. Now, the thing is here is that the thumb will still represent the anterior of the patient, and so the probe marker side or screen indicator side is still going to be anterior on the patient. If the uterus is retroverted, it folds across the screen and the fundus points posteriorly. So you can see here, again, it's just like turning it 90 degrees. So if we look at those side by side, you can see that an anteverted uterus has the fundus left of screen, a retroverted uterus has the fundus right of screen. When we turn into transverse, so we turn our thumb to the 9 o'clock position on the patient, now it's the same as our short axis imaging transabdominally, or the way we look at a chest X-ray. So the left-hand side of the screen is corresponding to the patient's right-sided anatomy, and the right-hand side of the screen corresponds to the patient's left-sided anatomy. Another way you can help to orientate yourself is to check where is the bladder. So the bladder is located anteriorly, and as we rock that probe in that longitudinal orientation, we should be able to see and locate the bladder, and it's anterior on the patient. So you can see here, the anterior of the patient, the bladder will be over here. And for the retroverted uterus, here is anterior again. The bladder still stays in the same spot. The uterus is folding away or pointing away from the bladder. Now, sometimes, typically we have our patients empty their bladder before a scan. For the transabdominal scan, we want to fill the bladder to push the uterus in a more horizontal position so that we can get specular reflection from the endometrium and from the uterus so that our imaging is as best as it can be. In the transvaginal exam, we need the bladder to be completely empty because if the bladder is full, it pushes the fundus of the uterus, particularly the anteverted uterus, it pushes the fundus of the uterus away from the probe and deeper in the image. And then we get this reverberation artifact that comes across at the bottom of the image. And so particularly if you're scanning in early pregnancy, this artifact inevitably falls exactly where you're looking for the gestational sac. And so the only way to correct for this is to pull the probe out, ask your patient to go and empty their bladder and start again. There's no way of getting around it. So for a transvaginal exam, we definitely need an empty bladder. Now, there are some differences to the probe moves that we can do with transvaginal ultrasound. Could whoever has their microphone on, could you turn it down or turn it off, please? So when we scan transvaginally, we can't slide the probe. We can't physically translate or move the probe in that long axis. It's in a fixed spot, and we can move the handle's position, but we can't actually move the tip of the probe within the anatomy. And likewise, we can't move the probe from side to side and move the tip of the probe or the footprint of the probe. We can't move that side to side because it's fixed in that tight spot. And so the probe movements are a little different for our transvaginal scanning. We need to push the probe, and when we put pressure on, we get better contact with the organs. The other reason we use pressure is to test the mobility of organs, and in particular, the mobility of the ovaries. And for those who do more advanced scanning, we also test the mobility of the uterus to look for any endometrioma deposits in the endometriosis deposits in the pouch of Douglas and around the uterus. When we rotate, we change the orientation of the image from long to short axis. So when the probe pressure, what that looks like on the scan, we're advancing the probe into the vagina and we're coming closer to our anatomy and getting better contact. And this is the difference that it will make to your image. If you have the probe advanced enough, you should get good contact with the ovaries and good sound and uterus and good sound transmission. Here's an example on the ovaries. So applying a little bit of probe pressure brings that ovary closer to the probe and helps to visualize the ovary much better. Rotation comes from the wrist. So when we are changing from a long axis to a short axis, motion comes from the wrist, and we go from the thumb at the 12 o'clock position to the thumb at the 9 o'clock position in a transverse orientation. So here we're in long and it rotates, and now we're in a short axis view. I know when I'm in a good longitudinal view because I can see the endometrium all the way from the fundus all the way through the cervix. I know when I'm in a good transverse view because the endometrium should be in the middle of the myometrium, and all aspects of the myometrium should be even. So as we turn into transverse here is even, it's even there. And then laterally, we have the same amount of myometrium on each side here and here. Now, the other movements that we have are rocking and fanning. And just like in transabdominal ultrasound, when we rock, we move the probe along the long axis of the probe. When we fan, we move the probe across the short axis of the probe. Rocking will change the position of your field of view with respect to the organs that you're looking at, and it will put structures in the middle of the picture. Fanning is the motion that we need to use to create the slices and to build up that three-dimensional picture of the anatomy. And so in each of the longitudinal and the transverse planes, we need to rock to position our anatomy, and we need to fan through the organ so that we can build up that three-dimensional picture. So in longitudinal, rocking will change the position of the field of view with respect to the anatomy. In transverse, it does exactly the same thing. It will change the position of the anatomy, or the position of the field of view with respect to the anatomy. So this rocking motion along the length of the probe will center the organs in the middle of your field of view. If we look at that in real time here, and then on a patient, This is what allows me to see more of the fundus or rocking more of the cervix. So depending on where your point of interest is, you may need to move the position. A multi-gravid uterus will often not fit on one single picture, so you will need to move it around a little bit. When we rock transverse, we're essentially moving the handle of the probe from one leg to the other leg. And I know this is a really obvious point to make. We all know that the vagina is stretchy, babies come out. But you need to remember that when you're doing your transvaginal ultrasound, the probe can have quite a big range of motion. If your patient is lying in a frog leg position, you will be able to comfortably move the probe from one leg all the way to the other leg. And we need to do this sometimes to get the field of view on the anatomy that we need. So when we are rocking the probe, you want to be able to move the probe handle from one leg to the other leg. And again, that rocking motion will put your organs into the center of the field of interest, or will change where your field of view is with respect to your anatomy. Now, if we move on to the fanning motion, in longitudinal, we're moving the probe from left leg to right leg, and we're creating that three-dimensional scan through the anatomy. In transverse, in the transverse plane, the handle will come up and move down so that we can see the anatomy from the fundus all the way to the cervix. So in longitudinal, another view on that, we move the handle from left to right. So we're moving our handle across the short face of the probe, and that's what allows us to create the three-dimensional scan of the organ and build that three-dimensional picture. Another way to think of it, we're kind of moving our probe this way, so we get to see the midline and then the edges of the uterus. And we need to scan from one lateral border of the uterus all the way to the other. And then when we fan in transverse, we need to see all the way from the cervix all the way to the fundus. So this will have your thumb at the 9 o'clock position and you're moving your hand up and down. So we see cervix here, and as we move our handle down, we'll see the fundus of the uterus. So essentially what we are doing as we're moving is cutting slices coming through the uterus like this. So when you're at the vagina or at the top of the cervix, it should be a small round circle. And as you come into the lower segment, that circle gets a little bit bigger. When you're in the body of the uterus, the circle will be bigger and you'll see the endometrial stripe in the middle. At the fundus, your endometrial stripe will be at its biggest point, and as we move past the fundus, we won't see any endometrium. And so we are rocking up and down. And essentially, fanning, I should say, we're fanning up and down, and essentially we are going from one side to the other side to create a three-dimensional view. So you can see in this animation, the rocking motion is along the length of the probe. The fanning motion is across the short face of the probe and creating the scan. And when we compare that on a transverse image, we rock to position organs in the middle of the field of view. And again, the fan motion will create the slices and allow that three-dimensional scan. The next top tip is being mindful of how you insert the probe. Now, I'm going to assume that you're all quite capable to gain consent and explain a procedure. I will comment, though, that when I do talk to my patients, when I'm consenting my patients, I always do warn them that I do need to move the probe while it's inside you, so that that's something that they're expecting. Otherwise, it can be perceived in all kinds of ways. If you can understand how the image is oriented and what probe moves we're making, the next step to being successful at getting the ultrasound of the transvaginal views of the pelvis is to insert the probe correctly. So what I tend to do here is that I put the probe just inside the introitus. So I've lifted the sheet. I don't use the other hand to part the labia or anything. I just pop the probe with a lot of lube on it just inside the introitus. I then cover their legs and I'm watching the monitor from here on in. And as I watch the monitor, I want to watch the urethra and bladder and then go forwards a little bit more until I get contact with the uterus. Now, if I watch the monitor as the probe comes in, I can start to see, is that uterus anteverted or retroverted? And then I need to adjust my position accordingly. So, and you'll notice here that I come in horizontal on the bed so that I have got the option to see whether this uterus is anteverted or retroverted. So if you insert the probe parallel with the bed or come in horizontally, it lets you see the anatomy on the way in and figure out which way things are lying. So you can see in this example, as we insert the probe here, you can see the bladder left of screen and the urethra. And I've just paused scanning here. So here's urethra and here's the bladder. I'm about halfway in at this point. Then we need to advance the probe. So bladder and urethra again, advance the probe a little more until we start to get contact with the uterus. And then I can adjust my position so that my uterus is positioned in the middle of the field of view and I can see the fundus in the middle of the field of view. Once you've inserted the probe far enough, you need to rock the probe up and down to get that uterus in the middle and to optimize the positioning so you can see the most of the uterus that's possible. As I mentioned before, a multi-gravid uterus will often not fit completely on the screen. So you have to sort of scan the fundus of the uterus separately to the inferior part of the uterus. How much pressure you put on, if you're watching your screen as you come in, you'll be able to see it come into view and you'll know you have enough pressure. Here's one of those times you need to sort of have one eye on the patient and one eye looking at your screen to be careful about not inserting too far and causing the patient discomfort. Now for an anteverted uterus, the probe will come in horizontally and then I'm going to rock my hand down and point the ultrasound crystals up so that my field of view is pointing up to be able to see the uterus. And a retroverted uterus coming in horizontally, I can see it's retroverted. And then I'm going to need to move my hand superiorly so that the crystals point posteriorly so that I can see the fundus of the uterus. A common mistake that I see is when people insert the probe and they put it in too far and they go up into the posterior fornix of the uterus and they've come in pointing their crystals down. And so all you get is a picture of the bowel and your field of view is looking at the bowel here. That same problem can happen if you're expecting an anteverted uterus and you point your crystals too anteriorly and instead the uterus is positioned retrovertedly and so you can miss the anatomy altogether. So that's why I come in horizontally. I want to look at the anatomy on the way through, note where the urethra and the bladder is. So that helps me figure out where anterior is. And then I can figure out where's the fundus with respect to the bladder. Is it on the same side of the image as the bladder, which is anterior, or is it on the opposite side, indicating a retroverted uterus? Now, I use the uterus as home base. If you can find a longitudinal image of the uterus, assuming they have one, this then becomes your home base and everything branches from there. So if I can find longitudinal of the uterus, I know how to do my transverse sweep because I just need to rotate 90 degrees. If I can get back to a longitudinal view of the uterus, I know how to go about finding my ovaries. I come transverse on the uterus and then I rock my probe or fan my probe out to the side. So I always use uterus as a home base. And once you've got the probe positioned in the vagina in the correct spot and you have enough pressure, that's when you need to adjust your image. So I start with a very generous depth setting so that I can see everything that I need to. And then I optimize and bring the depth up, adjust my frequency. A lot of the time you do need to lower the frequency on your probe to get enough penetration, particularly on your multi-gravid uteruses or patients who have lots of fibroids. So if you adjust the frequency and lower it down, bring the depth up so that you see the anatomy that you need, and 1 or 2 extra centimeters of depth so that you can see the relationship of the anatomical structures in relation to your target. Make sure your focal zone is in the right place if you have one. If you're on a point of care machine, they often don't have a focal zone. You need to have your depth set correctly, and then your focus will be right. And then adjust your gain so that your uterus is mid-level grey. Now, the way I approach the scan is to do a scout scan first, and very carefully, as I've explained, insert the probe so that I can figure out, is it anteverted or retroverted? And then I do a quick sweep in longitudinal just to get the lie of the land. Is there fluid? Is there any big fibroids? Is there any big cysts or anything like that? I move on to assess the uterus, and I think of the uterus as 3 distinct passes or 3 distinct parts. So I will make one pass in longitudinal and transverse evaluating the cervix. I'll make another pass to evaluate the myometrium and to take any measurements that I might need to of the uterine size. And then I scan again and I focus my attention on the endometrium. I think if you try and lump it all together and you try and see everything all at once, you're inevitably going to miss things. So if you adjust your scanning technique to evaluate the cervix, the myometrium, and then the endometrium, you've got all your bases covered. And then move on to the right adnexa. Typically, I'm looking in the adnexa for any adnexal masses. I'm trying to see the ovary. And then I move on to the left side and repeat the same process. Now, if I'm having trouble finding one of the ovaries, I go over to the other side and just try to replicate where did I see it on this patient on that side, and hope that that helps me find it again on the other side. I don't know that it's necessarily in the same place, but I think what happens as I do that is that my window changes slightly, because as I've moved around trying to get to the other side, I've come from a different spot just subtly, and then I can see on the other side clearer sometimes. And so the trickiest part of the transvaginal ultrasound is how to find those elusive ovaries. And one of the most common questions we get here is people who are just frustrated they can't find the ovaries. They're grey, fuzzy things. Transabdominally, they're just about impossible, particularly on some of the point of care systems, and if you're not very experienced. I'm going to put it out there, if you're doing transvaginal scanning, you need to do 70 to 100 scans before you're going to start to feel any level of confidence that you're finding ovaries consistently, or be able to say, I can't find the ovary because it's not able to be found on this patient. It's not my technique. It's not my imaging. It's because I can't find it on this patient. So 70 to 100 scans. If you're doing 70 to 100 scans, that's not over 3 years. It's 70 to 100 scans in a really short space of time to build up, maybe 6 months, to build up the confidence and to build up the skills. So let's look at these ovaries. If we have a look at this anatomical model here, you'll notice that the ovarian ligament is attaching the ovary to the lateral wall of the uterus here. And that ovarian ligament, along with the mesovarium and the vessels to the ovaries, all sort of gets sandwiched into the broad ligament, which is this sort of flat structure at the side. Now, why do I tell you about this? My broad ligament is like my yellow brick road to the ovaries, or my grey brick road to the ovaries. When I'm in a transverse orientation of the uterus, if I look at it end on here, that broad ligament provides like a thin band of hypoechoic tissue extending from the cornu of the uterus. And I follow that. At the end of that, I will find my ovaries. And so in transverse, with my orientation, with my thumb pointing to the patient's right side or the 9 o'clock position, I go to the fundus of the uterus and find the cornu of the uterus. So it starts to get a little bit pointy at the side. And then all I do is move my probe, my handle over to one leg so that I put the uterus as a reference point on the edge of my image, and I've maximized how much my field of view has got the right adnexa in it. From here, in that transverse orientation with a really wide field of view, I fan my probe looking for that hypoechoic band of tissue and seeing if I can see that tracing down to where the ovary is. So on the right side, we're at the fundus of the uterus here. I just move my probe over to the patient's left leg, and then I fan up and down. And you can see this hypoechoic band of tissue in here. And I'll just wait for the loop again. So you've got uterus and the cornu, this hypoechoic band. Here's the ovary just sitting in here as I'm fanning through. On the other way that I look for the ovaries, the adnexa is defined as the area between the lateral edge of the uterus and the iliac vessels. So as long as I have uterus on the one edge of my picture, like we have here, and iliac vessels on the other side, the ovary will tuck in quite commonly just beside those iliac vessels and just medial to those iliac vessels. So we have the artery and vein here, we have the uterus here, and I'm looking at the ovary just in here. Now the left ovary, again, we're at the fundus. We're going to move the handle of the probe over to the patient's right leg this time so that our field of view is pointing to the patient's left. And then we're fanning the probe or moving the handle up and down to find the ovary. You can see the ovary tucking in just in here, right next to the iliac vein and the iliac artery there. Another really key point for looking at ovaries is how much pressure. And what you need to think that you're doing, you're not going to feel this on the end of your probe, but you need to think about advancing the probe into the fornix of the cervix. And that'll bring you closer to the ovary. And if you've got the right amount of pressure, you can delineate the ovary much more clearly here. Now that's all good and well if you put a bit of pressure on. Before you move the probe and sweep over to the other side, I want you to ease off the pressure, because if you drag that probe on full pressure, if you drag that probe across the cervix, it's quite uncomfortable for the patient. So think about advancing the probe up into the fornix to apply a bit of pressure. You may need some external pressure on the abdomen from the anterior to push down to try to displace some of the bowel gas, and you kind of try to sandwich the ovary between your top hand and the bottom hand with the probe. And then before you move on to the next thing, ease that pressure off so that you don't drag it across the cervix and cause the patient discomfort. So I hope that through all these tips, we've had a look at and trying to understand how the image is presented. We've talked about the probe moves. I've quickly talked about how I approach the exam, and then some tips and tricks around finding the ovaries. So I'm now going to hand over to you. Does anyone have any questions? Don't be shy. I like people to talk to, so feel free to ask some questions. Or does anyone who is scanning transvaginally, do you have any other tips that you'd like to share with the audience tonight?
Sue-Ann, it's Louise Harper in New South Wales. Thank you for that. It was really good, and I liked the way you were the way that you've presented that, the imaging of what you're looking at, and then transposing that onto what the anatomy is, if that makes sense. So I found that really helpful. I have been doing some vaginal scanning, just follicle tracking, but I'm still, I think, you know, listening to you, I think I've sort of said to myself, oh, okay, well, that's what you're doing. So I've had the probe going towards the bed instead of horizontally. Mm-hmm. And then today, I did a scan today, and for the life of me, I couldn't find that uterus on transvaginal probe. I just couldn't find it. I thought I could see it, but then it was pulsing, and I was thinking, well, it can't be a vagina if it's like, it can't be a uterus if it's pulsing, and I'm like, all this stuff is happening, and the woman was clearly uncomfortable. So I kind of was getting a bit stressed and panicked about that. And I ended up, I found both ovaries, but I still couldn't find the uterus. So I took the probe out and then I had a look transabdominally and I found it. So I don't know whether that's something that happens.
I have done this a lot when I was learning and before I was doing consistent transvaginal scanning. I used to do that all the time and I would get lost. And my biggest tip for you there is when you're inserting the probe, you just get the probe just inside the introitus while you're looking, and then look up at your screen, and the insertion happens while you're watching it on the screen. As you're coming in, you're looking for urethra and bladder, that's anterior. And then advancing your probe slowly, you'll come into contact with the uterus. I think what people do, and I know I did this a lot, is you put the probe right in and then you look up here and you're already in the posterior fornix and you're scanning bowel because your field of view has gone past the uterus.
Yeah.
But when that happens, it is withdraw the probe, level it out. So that's why I do come in horizontally, because then whichever way it's going, I can see the uterus somewhere. Or if it's axial, which I haven't got nice pictures of an axial uterus, you never can find them when you want one. So yeah, I know that's how I used to get lost all the time. I'd come in with a little bit of handle up, pointing backward. Yeah. I'm sitting in the posterior fornix and I'm seeing all this bowel, and for the life of me, I can't get to the uterus because I'm already too far up in the fornix. So withdraw the probe. You can't feel it move on the cervix, and you can't feel that motion on the end of your probe. But if you think about, withdraw from the fornix and think about just adjusting the position of your tip, often that can help as well.
I think I started to panic because she was uncomfortable, and I'm starting to like, oh God, and I'm going, up and like sideways and back up and trying to, and I'm like, oh my God, and I'm like, oh my God. And then I just thought, oh, I've got to bail on this. I've got to
stop. And when the pressure's on, it makes it harder to step back and take the breath and go back to first principles. We've all had that happen, whether it be doing ultrasound or something else in our life. As soon as the pressure's on, it's harder to kind of get back and just think about, where am I going wrong, and to troubleshoot with a clear mind.
Yeah.
So I would encourage you to just practice that probe insertion technique and be mindful of where you are as you're inserting the probe, rather than, under the sheet, shove the probe in, okay, we're in, and then coming and looking here. I find if you watch the probe as it advances in, you see the uterus on the way in, and then you can adjust your position. Think through, is that fundus coming on the bladder side? My hand needs to go down. I need to point the crystals up towards the front because the uterus is coming forward. Is it retroverted? Well, I need to put my handle up and I need to point my crystals back to be able to see the fundus. The other thing, you can get one of these little uterus things on eBay quite cheaply. And I find when we're teaching here, having these anatomical models, where you can come back and think about, visualize what you're actually doing with your probe to help you figure out where you are. And if you can, you can make one of these at home with the back of a Weet-Bix box, and you can make a sector, cut it out, and use that to help you visualize where the scan plane is, to help you find out, which way is up, which way is down. Draw the probe marker on one side, which way are things. So they're the sorts of things that we've done, and I've tried out at different times along the way.
Thank you. Yeah, it was good. Thank you.
Thanks so much. Does anyone else have any other tips, suggestions, questions?
Yes, I have a question. Most of the time here where I practice, I will often find the ovaries behind the uterus. So what is accounting for this reason, displacing the ovaries behind the uterus?
I personally, one of mine sits behind my uterus. Some people have brown hair, some people have blonde hair. Some people's ovaries sit in this classic anatomical position like the textbooks would have us believe everyone sit there. Other people, they sit in different spots. I guess it depends. If you've got a multi-gravid uterus, perhaps things are stretched along the way. They're sitting on the end of a ligament. They're quite mobile, so they can sit quite posteriorly, which is why you do need to have a good look behind the uterus. The classic position is not always where they are, and it's actually quite common to find an ovary sitting in almost in the pouch of Douglas. It's just anatomical variation, and we just have to find them and then image them well and see if they're normal otherwise.
Thank you.
No worries. Are there any other questions?
Hi, Sue-Ann. It's
Hey,
Louisa. Hi. Thank you. That was a really great presentation. Unfortunately, my internet dropped down a couple of times, so I missed some of it. But I'm mostly doing transvaginal scans to check positions of Mirina's once we've inserted them. And I've only been doing scans for about 6 months, so I'm still a beginner. I find it's very rarely can we see that nice sort of T picture of the IUD. We're just getting little glimpses of it, and what I'm relying on is the shadow of the IUD to know that it's in the right place. Have you got any tips for sort of lining up the IUD and getting a better view?
So the Mirina's, as I understand it, and someone kindly gave me an old one so that I could have a look at them because I was curious, but it's a really thin polymer plastic.
Yeah.
And in longitudinal, if you're perpendicular to it, you'll get a nice reflection from the length of it. And that's the one that tells me, are you at the fundus or not? And I think it's from memory, optimal positioning is within 3 millimeters of the fundus. And if it's within that amount of the fundal endometrium, it'll get to the right spot. If you're further down the uterus, it's malpositioned. In transverse, you'll just see that tiny little, because now we've got a thin thing, and our beam is coming down this way, so we might get a little bit of shadowing from it, like a strip of shadowing. As you come up to the fundus, because you've got that T shape, as you come up to the fundus, when you scan through the uterus, you should be able to see on some of them where the T shape comes out, but it can be tricky. Part of that is just because that's what they're made of, and so it's the copper T ones were much more reflective to ultrasound because they're metal and you could get a good sound reflection of them. But the Mirina's are like that really thin polymer plastic. So as best as possible, we need to get 90 degrees and have our sound interact with it at 90 degrees to get reflection from it. So long, you'll get the white line when you're right in the middle of it, but not necessarily shadowing. In transverse, in the body of the uterus, you'll see the shadow. As you come to the top, you might see where it splays out, but it does take a little bit of practice to see that.
Thank you. I guess the other thing that I wouldn't feel confident calling is if there's been like a penetration of the myometrium. Have you got any tips on what we're looking for there? So
the IUD needs to sit within the endometrium, and the endometrium is quite linear. Yeah. If you've got someone with a really anti-flexed or retroflexed uterus, well, then that increases the chances that, you know, it goes straight up rather than around. I've never put one in, and I don't know what it feels like at the other end. But when I'm scanning on ultrasound, I want to see that Mirina or the IUD sitting along the line of the endometrium. If it veers off there, you start to see it. The endometrium is usually quite thin in these patients because of the hormones that's on the IUD. And so it's usually quite thin, and that's all you'll see. And so if it goes into the myometrium, you see it veering off into the myometrium and into the grey sort of muscle area of the myometrium, and it's not following the endometrial cavity.
Okay,
I think it's a numbers game, and if you even just go to just Google malpositioned IUD ultrasound on the images and just look at lots of pictures and just build up your pattern recognition of it. Whenever I'm wondering, and for anyone who's doing our courses and they're like, what does abnormal look like? The pattern recognition comes easy. You just need to look at lots of images. And you can just, as I said, Google IUD malpositioned ultrasound and a transvaginal ultrasound and click on the images and just see what comes up. The scanning part of things is the harder bit. Getting the images and being able to make sure you've scanned the whole uterus from cervix through to fundus and from left through to right. That's the trickier bit. The pattern recognition, it's just a numbers game, and the more you see, the more comfortable you feel. Now, someone commented, Kylie commented, you'd love to see us rotate the image so that it makes sense. And I wholeheartedly agree. When I've seen oocyte retrieval and the docs that are doing egg collections, they flip the image up the other way so that spatially it makes sense. Some of the Europeans have their ultrasound image for gynecology upside down compared to how we do in Australia. And if you learn that way, it all spatially makes a whole lot more sense. However, the convention in Australia is that we present it with the sector, the probe, a bit closest to the probe is on the top of the image. And I agree with you, that's one of the most confusing things about transvaginal ultrasound until you get your head around which way's up and where things are. I wish there could be some sense about this, but you know, the cardiologists put their probe marker on the other side just to confuse us as well. So we didn't create the rules right at the beginning, and that's a pity.
Hey, Sue-Ann, can I ask another question?
Absolutely.
What are your tips for avoiding a sore arm?
I did my shoulder doing transvaginal scans. I may not be the best person to preach, but when I'm teaching other people, bed height is hugely important. So make sure if you've got a bed that can go up and down, make sure that you adjust the height of the position. Before you get the probe in too much, adjust the height of the bed. I want you to keep your elbow in front of your body, not be scanning with your elbow tucked behind your body. That's how I did my shoulder way back when. So keep your elbow as close to your body as you can while still being able to. So the patient needs to move as close to you as possible, and then elbow in front of your body so that you, and I rest on the patient as well, so that on their legs, so that I've got a bit of support. Now I need to warn the patient, I'm just going to rest here just to support my hand. Some people are a bit funny about that, but I find that also helps to stop their legs shaking, because if you're there for 10 minutes or so, it can be quite hard holding your legs still. So if my arm is sort of tucking their knee under the crook of my, in my armpit, and keep my elbow forward at the right height with the bed. If that means you're sitting up, fine. Some people are standing up. I scan transvaginally standing up. I don't think there's a right and a wrong. It's where you're comfortable. If you feel it as you're scanning, if you feel your muscles getting tired, you need to adjust your position until they're not so sore, until you find your comfy spot. And, you know, for some exams that we do, finding your comfy spot to scan is half the battle. I know when I learned shoulder ultrasound, it took me ages to figure out where am I going to sit so that I'm comfortable and I'm not hurting, but I can be stable to get my images. As I practiced clinically, I stood for some things, I sat for some exams, and I changed my position so that I could give different parts and try to look after my body. So it is about finding your comfy spot. The bed height is critical, and keeping your elbow in front of your shoulder. Does anyone else have any other questions?
Yes, well, here in Cameroon, where we practice, when a patient comes, you don't go directly to do transvaginal ultrasound. First of all, a transabdominal ultrasound is done so that you can see the scoop of the pelvis and the uterus. then before you continue to do a transvaginal scan so that you don't miss out some pathology.
Yep.
That is our
That's my
protocol.
that's my preferred approach too. I have worked in some practices where just because they're trying to churn through the numbers, they always asked their patients to arrive with an empty bladder. I personally don't like it and have a problem with it for a couple of reasons. I want to do a quick transabdominal scan to get the lie of the land. If you've got a patient who has massive fibroids, you're not going to be able to see that very well transvaginally. I'm looking for really big pathologies transabdominally. I'm also using the opportunity while I'm scanning transabdominally to build a relationship with that patient and to talk about the vaginal scan and explain what's going to happen. Rather than just walk in the room, I'm going to do a transvaginal scan and we're going to stick this in your vagina. So I use the transabdominal scan to get the lie of the land. I do a quick survey. If they've got an empty bladder, it is just a cursory look to sort of say hello to the patient, build a relationship, and then move on to the transvaginal. So I think for me, that transabdominal scan is as much about gaining proper consent that is not pressured because of time constraints, because you haven't got time to fill up your bladder, or I didn't know I had to have a bladder, and oh, I'm doing a transvaginal scan because there's no option now because my bladder is empty. So I like to have a full bladder to start with. I do the transabdominal scan, do the big picture views. I explain the vaginal scan. I get consent and talk through the different things about the vaginal scan. I then get them to go to the bathroom. They're fully clothed. They come back in the room. I'm checking again. Are you happy for me to proceed with the vaginal scan while they're standing up, not when they're on their back in a vulnerable position? If they're happy to proceed, I'm getting everything ready, step out, they get undressed. I check another time as part of my consent procedure. Are you happy to proceed with the scan? Are you okay for me to insert the probe? And I wrote a paper, it was a draft paper many years ago. And when it went to the lawyers, and this was about consent for transvaginal exams, when it went to the lawyers were like, it's one thing to consent for the transvaginal exam and an entirely different consent for you to insert the probe. So I ask for both. I give my patient the option, would you like to insert the probe or would you rather I do it? Now, some people are really uncomfortable with doing that in front of you. So they're like, no, you do it. I'm completely divorced from the lower half of my body. And for others, they're quite happy to do that and it feels more comfortable. And I think that for me stems from the fact I was taught by a male sonographer. He worked by the process that if the patient has put the probe in, they have consented and they know what's going on. And it was part of his checking that they understood what they needed to do. So he always asked the patient to insert as part of him protecting himself medico-legally from accusations of foul play or whatever. I don't know that it's necessarily the best of protections, but it is one way. And so it depends. I mean, everyone's a product of the history of their cases. And it depends what's happened along your career, where you get to and how you approach things. But that's how I go about it. And as I mentioned before, I do always mention in my explanation, once the probe's inside you, I need to move it around to take my pictures. I may need to push on the top of your tummy to get a better view at times so that they're expecting that because I heard of a case where a patient, the doctor had used a glove to cover the probe, but hadn't wrapped the fingers around. So the fingers of the glove were hanging down and were tickling the patient's backside. And then the probe was being moved for the scan, and they weren't sure whether it was the fingers of the glove or whether it was the doctor's fingers as he was doing the scan. So, as I said, we're all a product of the experiences and the stories that we hear. That's how I go about explaining, and my preferred approach for transvaginal is to start with a full bladder and scan transabdominally first so I can get good consent and know that they understand what's going on. Okay, does anyone else have any other questions? Otherwise, we might wrap up.
No questions, Sue-Ann. That was very good.
My name's Debbie.
Thank you.
Thanks so much. I really appreciate you all joining me tonight. If this has been helpful for your practice, feel free to share the link. We'll have it up on our website in the next week or so. We'll have it up on our website that you can review it again at a later date. Feel free to share that with your colleagues. If you thought it was helpful, feel free to leave us a Google review. It would be really great. And I appreciate you all coming. Thanks so much for joining me, and hopefully we can see you again next month. If anyone has any ideas for topics for next month, the slate is open, so you can get in touch, and perhaps I can.
Can you hear me?
Yes. Hello? Yes. I've just got iPad, so I'm going to call you iPad.
Can you hear me?
Yes, I can hear you. It's a bit.
iPad, yeah. iPad. I just wanted to know the one-day course.
Yes.
Hello. The one-day course that you do, is that face-to-face? Where?
It's face-to-face. Our training headquarters are in Melbourne, and we have real patients come in so that you can practice scanning on real people during the course.
Okay. And is all the information on the website about cost, etc.?
Yes. So if you look on the website, our website's all the W's at ultrasoundtraining.com.au. And you'll see either course by specialty or whether it's live course, online course, or whatever. If you go under the obstetrics tab, it's listed under the obstetrics and gynecology tab.
And how often do you do that one day?
I think this one runs 4 times a year from memory.
I think it ran yesterday or today.
Yeah, only
You
just
missed out.
this week, last week. I think last Friday we ran one. So it does run, I think 3 or 4 times a year. If the dates don't suit for whatever reason, you can get in touch and we can do a tailored course where it's just for you, and can do it when it suits.
Okay, thank you.
No worries. Well, thanks everyone for joining me. Hopefully we see you again. I hope those tips have been helpful, and I hope you have a lovely evening.
Thanks, Sue-Ann.
Thank you. Thank you.
No worries.
Thank you.
Thank you.
Thanks, Henry. Thanks for your questions.
Thanks, Sue-Ann.
No worries, Kirsten.